Next case discussion is upfront therapy for those who are eligible for transplant and also consideration of consolidation and what maintenance should be used. And so please welcome Philippe Moreau.
So good afternoon. And we are going to discuss this case, 63-year-old male with symptomatic myeloma with diffuse bone lesions, normal renal function, low beta-2-mic level, LDH below normal, and then the patient is diagnosed with a symptomatic myeloma, ISS1, revised ISS1. So what is your choice? Are you proposing VCD, stem cell transplantation, LEN maintenance until progression, VRD from 4 to 6 cycles, single stem cell transplantation, LEN maintenance until PD, VRD times 8, LEN maintenance and delayed stem cell transplantation, patient is at a good risk, KRD times 12, LEN maintenance and delayed stem cell transplantation at the time of the relapse, or a more aggressive treatment, VTD DARA times 4, stem cell transplantation, VTD DARA consolidation, LEN maintenance, or VRD DARA, single stem cell transplantation, VRD DARA times 2, consolidation, LEN DARA maintenance 2 years, or you don't know, you're not sure at all about your optimal treatment. So please vote.
So a lot of options.
So choice number 2, VRD from 4 to 6 cycles, single stem cell transplantation, LEN maintenance until PD. Quite interesting. So what is the opinion of the expert panel, in fact? Well, that's very, very similar. So this symposium is changing. In fact, we were arguing and fighting a lot in the future. Now there is a consensus, in fact. VRD, stem cell transplantation, LEN maintenance. So let's discuss, in fact, what are the current European guidelines. We are proposing when patients are eligible for stem cell transplantation, less than 70 years, fit patients, we are proposing a triplet induction, VTD, VCD, or VRD, single stem cell transplantation, and LEN maintenance. Why? We are never proposing in Europe delayed stem cell transplantation. This is based on the IFM study, VRD plus stem cell transplantation and LEN maintenance in the two arms of the study, comparing stem cell versus no stem cell transplantation up front. And you know that the progression-free survival in the transplant arm is highly improved, 50 months in median versus 36. And into the study, very interestingly, we looked at flow cytometry, 7-color flow, to assess minimal residual disease, MRD. The threshold was 10 to the minus 4. And when you are reaching MRD negativity, the overall survival is improved as compared with MRD positive patients. So definitely MRD negativity could be an endpoint of our future trials. So why VTD or VCD or VRD? VRD was recently tested into the Spanish study, 6 cycles up front before stem cell transplantation. And our colleagues reported this analysis very recently, 2 months ago in Blood. And you see that after 4 cycles, the VGPR rate or better is 63%, increased up to 70% after 6 cycles. So the benefit is not that important. Nevertheless, there is an increased response rate. Very often we are asking, should we use 4 or 6? We don't have any randomized study comparing 4 versus 6, but here you see that when feasible, potentially, it could be interesting to increase the number of cycles before stem cell transplantation. After patients did receive a single stem cell transplantation, 2 additional cycles of VRD, and you see that the response rate is deepening over time. That's quite logical with the addition of high-dose melphalan and 2 cycles of VRD consolidation. The same group used VTD 6 cycles in the past and published this experience in 2012. And when you are comparing the 2 consecutive analyses, VTD or VRD times 6, you see that the toxicity is totally different, in fact, and especially in terms of peripheral neuropathy. With VRD, when you are switching from thalidomide to lenalidomide, you are dramatically reducing the toxicity of this regimen. The same group looked at this integrated analysis of VTD versus VRD. You have VRD results, 6 cycles in blue, VTD, 6 cycles in red, and you see definitely that VRD is potentially more effective, and this translates into a better progression-free survival with VRD and stem cell transplantation as compared with VTD and stem cell transplantation. So this paper is currently submitted for publication. They also looked systematically at MRD negativity with the Euroflow technique, 2 tubes, they color the threshold 10 to the minus 6 for them in their hand. And you can see that after induction, after 6 cycles, 28% of the patients are reaching MRD negativity. And this is a very high rate, 10 to the minus 6. And this rate is increasing after stem cell transplantation and also after consolidation and before maintenance. And recently, Bruno Paiva published a few days ago the MRD assessment into this study, VRD, stem cell transplantation, VRD, 2 cycles of consolidation and maintenance. And when you are looking at PFS before maintenance, for those patients reaching MRD negativity, the PFS is highly improved. But also, and that's very important, overall survival is highly improved when you are looking at the hazard ratio less than 0.3 in favor of the MRD negative group of patients before maintenance. So definitely MRD should be, to my opinion, an endpoint for future trials. Can we improve on VRD? We have KRD available and switching from bortezomib to carfilzomib. This is tested in the Forte study, a prospective randomized trial comparing KRD versus carfil cyclodex, KCd, and we know that with 4 cycles only after induction before stem cell transplantation, 4 cycles of KRD, the VGPR rate is at least 73%. That's 66% with 6 cycles of VRD into the Spanish experience. So potentially KRD is better than VRD, and Shaji Kumar is the PI of a very important study in the US comparing VRD prospectively to KRD. So definitely we will know if KRD is better than VRD. Another way of improving the induction part is to use a monoclonal antibody, and we tested in the randomized fashion VTD versus VTD plus daratumumab, both before but also after stem cell transplantation. And this Cassiope study showed that the DARA VTD, the quadruplet combination, was feasible. 90% of the patients were able to undergo stem cell transplantation in the 2 arms of the study, and the response were also increased with the addition of DARA on top of VTD. And this also improved over time after induction, after stem cell transplantation, and after the 2 cycles of consolidation. And at the end of the day, before maintenance into this study, the CR rate was highly improved with DARA. The stringent CR was also improved. We looked systematically at MRD negativity, 10 to the minus 5, with flow cytometry. For all patients, more than 1,000 patients were tested. And you see that before maintenance, in the DARA arm of the study, 64% of the patients did reach MRD negativity versus 44 in the arm without daratumumab. So definitely a very high MRD negativity rate when using a quadruplet combination, including a monoclonal antibody and stem cell transplantation. This quality of response translated into a better progression-free survival. You see here the final analysis of part 1 of the study before maintenance with DARA. Without DARA, the hazard ratio is 0.47. And we already have a trend for a better overall survival as well, although the follow-up is rather short, and this is not the final analysis of overall survival. You see the hazard ratio of 0.4. But definitely look at the overall survival rate, the 20-month OS rate in the DARA arm of the study. 97% of the patients on an intent-to-treat basis were alive. So unprecedented overall survival results with the quadruplet combination plus stem cell transplantation. This study, the Perseus study, is ongoing in Europe. This is the prospective comparison of VRD, and you are, all of you, or the majority of you, considering that VRD is the best option prior to stem cell transplantation, with or without daratumumab, before and after stem cell transplantation. And interestingly, the study is also looking at LEN maintenance or LEN plus DARA during a 2-year period of time. So very interesting study, and the secondary endpoint is MRD negativity. What about tandem stem cell transplantation? We had this meta-analysis of single versus tandem stem cell transplantation in phase 3 trials that were run in Europe quite a long time ago. And Michele Cavo last year, during this meeting, published the update analysis with a very long follow-up, up to 10 years. And you see that tandem is improving overall survival versus single stem cell transplantation after bortezomib-based induction, and this is especially true for high-risk disease. And some of us in the room are considering that when a patient is harboring 17p deletion, for example, or 414 translocation, tandem is a good option. But this is here a huge debate. Should we use tandem? Should we use consolidation after stem cell transplantation? And the STAMINA study run in the US was reported early this year in the GCO, and the study design is very interesting. After a single stem cell transplantation, patients were randomized to receive no consolidation and maintenance until progression, or VRD times 4, consolidation based on novel agents, and maintenance, or a second high-dose treatment, a tandem stem cell transplantation, then followed by LEN maintenance. And a very high number of patients were randomized, 750 patients, and disappointingly, I would say, no difference in terms of progression-free survival when comparing the 3 arms of the study, and no difference at all for overall survival as well. So the conclusion of the authors from the US was that we don't need any consolidation after a single stem cell transplantation, and we should proceed immediately to maintenance. So in Europe, we are favoring consolidation. In the US, consolidation is not used. But we, all of us, are considering that patients should receive a maintenance. LEN is standard of care, approved and reimbursed in many countries based on a meta-analysis of LEN versus no LEN or versus placebo. 1,200 patients were randomized, and you see here the overall survival benefit with lenalidomide. The benefit is almost 2 years, so that's quite an important discovery for the patients. This is the Tourmaline 3 study comparing ixazomib, an oral proteasome inhibitor, versus placebo, and the progression-free survival from the start of maintenance after a single stem cell transplantation is in favor of ixazomib, but you see that the PFS benefit is not that important, 5 months only, and we don't have any overall survival data. We need a longer follow-up. So ixazomib could be of interest. Len is definitely of interest. So why not combining these two agents, ixa plus len? And this is what currently the Spanish group is doing in a randomized fashion after stem cell transplantation. Our colleagues are looking at len versus len plus ixazomib, and potentially the combination of a PI and an IMiD with a synergistic activity will show an improvement in the duration of the response. We are also looking into Cassiope at DARA maintenance after consolidation versus no maintenance, and the landscape potentially will change in the future. And what are the guidelines going to show? For example, in 2020, we are currently updating the guidelines, and this is a question mark. That's not the final paper that will be proposed next year. For sure, we are going to propose more and more a quadruplet induction with a CD38 antibody. KRD potentially can become a good option, and we will have the results of VRD versus KRD. The tandem stem cell transplantation for high-risk disease, this is a question mark. And the maintenance part also will change in the future, len as a standard of care, but potentially len plus ixa or len plus a CD38 antibody. But what is very important is to look at MRD negativity, and I mentioned this very important endpoint for the future. Is it possible to anticipate the outcome of the patients after induction based on MRD assessment? This is some data from the Cassiope study, VTD, DARA, and stem cell transplantation. And we looked at MRD negativity systematically after induction and before stem cell transplantation. And we showed that not only DARA is important and is a very important, the DARA arm of the study is associated with a better progression-free survival, but also MRD negativity after 4 cycles of induction is a predictor for progression-free survival. So you can anticipate if your patient is becoming MRD negative after induction, the outcome will be very good. Well, this deserves some music for sure. So this is the landmark. Should I stay or should I go? Or should I stay or should I go? So this is the results of the landmark analysis post-induction according to MRD status. And you see that those patients reaching MRD negativity after induction and receiving a quadruplet induction are enjoying the best progression-free survival. So the last picture is the future French study, the IFM study. What are we going to do, in fact? We are going to use a quadruplet induction and assess MRD with NGS with a threshold of 10 to the minus 5. And when patients will reach MRD negativity, we can anticipate that the outcome will be favorable. And we are going to randomize no stem cell transplantation versus stem cell transplantation up front with a consolidation based on a quadruplet alone or quadruplet plus high-dose treatment with a fixed duration of maintenance. On the opposite, for those patients MRD positive, we are going to propose stem cell transplantation and a consolidation or a tandem stem cell transplantation based on the poor outcome suggested by the positivity of MRD. And I thank you for your very kind attention. So let's go back to the patient case, 63, symptomatic myeloma, ISS1, revised ISS1. You can vote looking at the different choices. We had 50% of the audience favoring VRD times 6. Is it going to change? Definitely we have an increased DARA quadruplet use with VTD DARA or VRD DARA. And well, this is the future, but that's very interesting.
Yes,
thank you.
Shift. Yeah. Okay, so thank you so much, Philippe, for that. So very slight shift there toward the future with the added benefit of DARA. So raise your hand if you have questions, but any comments or thoughts from our panel about this? It seems that so far we have VRD, you just have one recommendation so far from each session.
So Luciano Costa has an abstract that he's going to present at this ASH, which is daratumumab plus KRD. And they do a adaptive design, and they're looking at MRD as an endpoint. And when a patient achieves MRD negativity for 2 subsequent values, then the person stops therapy. So to get to Vincent's point, if we treat them very aggressive up front with a quadruplet, it's got to be with something, I think, some benefit at the end, that hopefully that we can stop early and actually give patients the benefit of being off therapy. So I do think we have to, going forward, we have to use MRD as our way to tease back some of the medications.
Right, a key point for full use of a four drug regimen. Yeah, we have a question here, number 1.
Number 2.
Oh, number 2, okay, number 2 is fine.
Hello, Professor Moreau, you have chosen a patient with translocation level 14, a subgroup when we have a targeted treatment, and venetoclax we know can work very well in the relapse setting in this subgroup. Do you think it's time to consider its use in the upfront setting as well?
Well, that's a very interesting question. Right now, we have some data with venetoclax in combination with bortezomib and dex in the phase 2 study that is already published with very good results. We know that venetoclax is able to target not only 11-14, but also BCL2 high patients. But we need randomized trials. I guess that the Bellini study is ongoing. We have other trials looking at POMDEX versus POMDEX, venetoclax in 11-14 in relapsed patients. Currently, that's too early to move to frontline treatment, although I'm strongly believing that it could be interesting, but we need some data that we don't have yet. But your question is a very good one, for sure.
Okay.
Ashley, number 6.
Hi, I'm Phil Imus. I think the IFM 2020 is a really important study to do, but in the absence of that data, right now, if you have a patient who achieves MRD negativity after induction, are you still recommending high-dose melphalan, given that their outcomes should be excellent, whether they get that therapy or not?
Okay, good question. What do you think?
Well, that's a very good question. You know, during this meeting, we are going to hear about KRD DARA without stem cell transplantation frontline. The paper will be presented by Dr. Landgren on Monday morning, and is claiming that we can reach 80% of MRD negativity with KRD DARA alone, in fact, and without stem cell transplantation in young patients. Okay, this is a fact. We can go in very high rate of MRD negativity, but also one way to increase the MRD negativity rate and the quality of the response is to use high-dose melphalan. So definitely, I think that we need a randomized study, so that's why the IFM will run this study.
I think it's also important to remember that the patient who is MRD negative before transplant, who did well in those phase 3 trials, got a transplant. So we don't know how they would have done if they didn't get a transplant. So I think it's premature to jump into that conclusion at this point without the data from phase 3 trials.
All right. Number 1 right at the front here, Jean-Luc.
It's a question from Nantes to Nantes.
Okay.
No, it's mostly a comment. Don't you see it about consolidation? Don't you think that the interest of consolidation is quite dependent on the quality of the induction treatment, which could reconciliate the US and European results? Because when there is a benefit of consolidation is usually because the induction has been short. And when we have a long induction with 6 courses of a good triplet or even more quadruplet, don't you think that at least for standard risk patient, consolidation will be useless?
Well, I agree with your proposal. I would like to see a study comparing 6 cycles stem cell transplantation with or without consolidation, but we will never have such results. But I agree with your proposal. When the induction is a very good and long with the quadruplet, potentially we don't need any consolidation.
Should we be aiming for Philippe? Should we be aiming for 6 cycles?
Well, this is the Spanish data are quite interesting with 6 VRD. We can, that's good to do 6 cycles, to my opinion, when feasible, when not too toxic, and the patient will be able to proceed to stem cell transplantation. And when looking at the feasibility of 6 plus stem cell transplantation, that's highly feasible. 90% of the patients were able to proceed to stem cell transplantation.
So for the 6 cycles, they had an innovation to use the 4-week schedule with 2 weeks of Velcade.
Yeah.
Is this something important?
We have different VRD proposals, 21 cycles, 21-day cycles, 28-day cycles. That's another point, in fact. And when you are comparing 4 cycles of KRD, 28 days, versus 6 cycles, 21 days. In fact, those intensity of lenalidomide and the dexamethasone is roughly similar. So we have to be careful regarding the number of cycles. That's also the number of months and the dose intensity that matters probably. So that's not that simple.
For IMW, that was one of the most common abstract submissions, is the comparison of 3-week versus 4-week RVD. And honestly, there was probably 14 abstracts. There was not a difference, didn't matter what the schedule was, there wasn't a difference in terms of the overall response rate. And really the CRs or VGPRs, it's all about the same. So I don't think there's much difference in terms of the, that.
Okay, so we have a question, another question over here, number 2.
In order to use MRD in standard clinical practice, we need a standard definition and a standard method. So I'm wondering what your opinions are on the state of things in terms of standardization of MRD.
First of all, in Europe, we are not using...
That's why I was asking this question earlier.
We are not using MRD outside clinical trials. NGS is quite standardized. Now, with flow, we also have this Euroflow technique that is well validated, 2 tubes, 8 colors. We can reach a threshold of 10 to the minus 5 quite easily. But we have some discrepancies. And for example, Dr. Landgren is showing 1 tube, 10 colors with flow cytometry. We need to be reproducible. That's very, very important. But Vincent can comment on MRD based on the I-square team assessment, that because we need to have MRD validated by the authorities as an endpoint, and there is a common effort from the companies and also from the cooperative groups to incorporate MRD in the routine practice. So maybe you want to comment, Vincent?
Well, you know, the subject of MRD you have to look at in terms of what is the purpose you're doing the test. So if you simply want to find out prognosis, is the patient going to do well or not? Just that. You could use any method. You could use flow, you could use sequencing, you could use -5, -6, and you will know, based on positive, negative, what the likely outcome is going to be. If your goal is, I'm going to use the result to change the therapy, either stop therapy because they are negative or add therapy because they are positive, then I think we have to be very clear that just prognostic information is not enough. We need randomized trials to show that acting on that MRD result is going to change the outcome. Those trials are ongoing, and those trials need to be done. You know, take MRD, give a finite duration of therapy, do the MRD test. If they're positive, continue the same treatment versus adding something. Or if they're MRD negative, stopping the therapy. Those can only be answered by randomized trials. And then we have the purpose which the I-square team is trying to answer, which is it's becoming increasingly harder to get drugs approved waiting for overall survival results or even PFS. So can we use MRD as a surrogate endpoint instead? And that is what the I-squared team is working on, to try and see if we can use MRD negative rates as a surrogate endpoint instead of overall survival. And then finally, it is the sustainability of the MRD negative and whether that will be a marker for cure. And what level of depth of MRD negative sustained for what period of time is reflective of what proportion of patients who are cured. That's a separate question. So I think just jumbling these 4 things into MRD as a thing might be confusing, but you have to just go specifically what is the purpose, and then the test depends on that.
I think going back to a specific question, there exists a standard definition. The IMWG defines it as 1 in 10 to the power of 5 as the sensitivity for defining MRD today. And we have specified that it can be either the next generation sequencing or the Euroflow methodology. Any methodology that is being validated to demonstrate the ability to get that sensitivity. I think going forward, we have to use that for all these randomized trials to prove the point. And the definitions will change over time as treatments get better.
Absolutely. Okay, I think that...
No.
One more question, okay?
From the
All
back.
right. Okay, a last question?
Yeah.
Go ahead.
Hi, this is Dr. Vishnu. So it's really encouraging to see the better results from quadruplets. Can you comment on the toxicity profile of quadruplets versus triplets, and also the patient's quality of life when using the quadruplets? Was there any significant difference, or you didn't see much difference in the toxicity profile and quality of life?
Well, that's a very good question, very important one. When looking at Cassiope, VTD versus VTD DARA, in fact, the feasibility of stem cell transplantation was identical in the 2 arms. We have a higher rate of infection, but not severe infections. During this meeting, we are going to hear Dr. Voris on Monday morning presenting the Griffin study, a phase 2 study comparing VRD stem cell transplantation versus VRD DARA stem cell transplantation. And there is not a significant increase in the toxicity with the addition of DARA. On top of this, we can anticipate that in the near future, we will have DARA sub-Q that is very well tolerated as well and very convenient also for the patient. So I guess that this quadruplet is really adding, and the ratio between efficacy and toxicity is in favor of the efficacy with a low toxicity rate.
Okay, and then I think, Vincent, you had a comment?
Yeah, I have 2 comments on an earlier question. The one was raised by Jean-Luc, and one was the gentleman who asked about the MRD negative patient. I want to comment on it mainly because when we come to the algorithms, I don't want it to be not covered. Number 1, the consolidation question. I don't do consolidation, and it looks like 50% of you don't do consolidation. That's why it's VRD transplant maintenance. That's the 50% vote. And I don't do consolidation because there is a randomized trial, the CTN trial, which looked at induction followed by a single transplant and LEN maintenance versus induction, transplant, consolidation, and then maintenance, and then induction, double transplant, and then LEN maintenance. That's the only trial that isolated consolidation. Patients all got induction, transplant, maintenance. One arm got consolidation, one arm didn't. And it showed absolutely no benefit to consolidation. It just adds another $300,000 or $200,000 extra of cost and toxicity when the patients just had a transplant. And so with good quality induction, I absolutely do not do a consolidation. That's just my personal view, because there's no data supporting its added value to maintenance in an isolated randomized trial. Number 2, as far as the MRD negative patient who is asking you, should I absolutely need a transplant? I think many, many physicians have come to me for opinion on that question when they get myeloma. And they really don't want to do the transplant because they want to continue their life as is. I just looked at I look at the randomized controlled trial data and ask the question, is there any randomized trial where if the patient just collected stem cells and opted for a delayed transplant, that they would actually survive less? There isn't. Maybe there's one, but there are 4 trials which say that there isn't any difference. Not only that, if the patient is on top of it MRD negative and standard risk, then I think we need to do the same thing we did for the smoldering myeloma patient. Tell the patient these are the options, and this is all the data we have. PFS may be longer, MRD negative rate may be higher, but you're already MRD negative, so I cannot make it any more negative. So I will tell you this is the data we have and do a shared decision making. And certainly there are many patients, I would say about a third of the patients at Mayo who are standard risk will opt for collect and store, which is okay only if you can collect and store forever, and you are definitely planning on doing the transplant at first relapse.
But I think the catch to that specific question is you are making that decision one way or other, irrespective of the MRD testing is done or not.
But if the MRD is negative, it's even more unlikely that the transplant will happen.
Now we are making the assumption that it's right because we don't have the data from randomized trials, just as you said. But I just want to get back to the point you made about the 6 cycles of BRD. And I think the point you made was that the depth of response went up from 63 to 73%, and that's why you prefer the 6 versus 4. But I'm not sure if there's data to say that an incremental depth of response prior to transplant actually translates to an overall survival improvement. Because the MRC trial clearly showed that if you give additional cycles of consolidation for patients or additional cycles of induction before transplant for the suboptimal responders, didn't really change the overall survival, only changed the PFS.
That's true, but...
Okay, well, I think we're going to have to move on. But it's interesting that we don't have much discussion about the choice of drugs, but 1 transplant or 2 transplants, quite a lot of discussion.